everyone. I'm Brian Lewis with Kidney Can, and it's my pleasure to welcome you to the joint edition of the National Kidney Foundation's Facebook Live series. Today we'll be discussing the topic of kidney cancer and what to do when you or a loved one has been diagnosed. Fortunately for us, we're joined by two experienced panelists. First, a distinguished urologist, Dr. Michael Polizzi. Dr. Polizzi is a professor of urology and chair at the Department of Urology at Mount Sinai Beth Israel Hospital, and is an expert on the subject of kidney cancer. He can help us make some sense of this difficult subject. And I'm also happy to introduce my friend Deb Bahan. Like myself, Deb has had an experience with kidney cancer. She's a kidney cancer patient from Georgia, a patient advocate who's been up to Capitol Hill, and she's going to share a little of her experience with us today. Thank you both for joining me today. I'd like to start off with you today, Dr. Polizzi. So tell us, help us set the stage. What is it like when you first are diagnosed with kidney cancer, and give us some background information.
Well, again, thank you, Brian. Thanks for the introduction, and really excited to be here and to talk to you a little bit about kidney cancer and obviously the staging and how we get to the diagnosis. Kidney cancer affects about 70,000 people in the United States alone. It's one of the top 10 cancers that we see, both in men and women. And so there's lots of different ways that, when there's a diagnosis that comes along, it becomes a very scary diagnosis. I think that most patients, when they hear this, they don't know what to expect, they don't know what to think. And so I think that's one of the first things that we have to do is figure out exactly what we're dealing with. Usually it's a tumor or a mass that's found in the kidney. It could be lots of different ways that this is discovered, whether there's symptoms or signs. But the most common way is during a imaging study that's done for a different reason than for the actual tumor. So for instance, someone walks in and has back pain or has an upset stomach, they may get a CAT scan or an ultrasound, an MRI, and lo and behold, we'll discover that there's a small tumor on there, or a tumor in general, and then things go from there.
Got it. That's called an incidental finding, by the way, right?
Correct. Yeah. Incidentaloma, actually, like a tumor that's just incidentally discovered due to a different reason.
Got it. Deb, do you want to give us your experience of what happened?
Sure. It's about 2.5 years ago, I experienced some bleeding. I thought it was gynecological. We ruled that out shortly and was sent to a neurologist. The urologist did an imaging, trying to find out why that was happening. And lo and behold, I had a tumor, pretty large tumor. And immediately they just started the process of get this scan, do this, go to this doctor, and then I had the nephrectomy. And after that, I found another doctor a medical oncologist that put me on a clinical trial, and I have been on that clinical trial for the last 2 years.
Got it.
Going strong.
Well, I share with you being a kidney cancer patient. I was diagnosed in 2007, and it was an incidental finding. And I was fortunate enough to be picked up by the NIH and studied, so I was fortunate to have a great team around me. But let's talk a little bit about the team and that concept. So I'll start, I think, with you, Deb. Can you tell us a little bit about how you assembled your team and the first people that were involved with this?
Sure. Well, initially, hearing the doctor say you have kidney cancer is overwhelming. And I think, as you mentioned before, this is kind of the white noise stage. You're not really comprehending everything that the doctor says. And I do recommend that you need to have a loved one or a friend come with you to these appointments initially and take notes, so you can know where your next steps have to be. Those initial first few weeks are very tough, and emotionally, psychologically, and you need all the help you can get. And then as you're progressing through your diagnosis, and the doctor is suggesting what you have to do next, and medicines and all that stuff, you are beginning to learn who else you need to consult. I went into it, fortunately, that I didn't have any issues, no high cholesterol or sugar issues or anything. But as you're going through this, you end up getting new issues that you have to deal with. And you may have to see radiologist, or you may have to see a podiatrist. Everybody is a little different, but as you're taking steps through the course of this, you need to continue to communicate and ask questions. Do I need to bring this person in? Do I need to bring that person in? And finding the right resources for all those different areas that you come across is what you need to do.
Great, great. So you touched on the C word. I can remember vividly the moment that I was informed that I had cancer, and it's life-changing.
Yes.
So I'm curious, Dr. Polisi, from your standpoint, you do this and see dozens of patients a week and deal with this every day. That must be emotionally and psychologically hard for you. Can you tell us a little bit about when you are confronted with this situation and have to discuss this with a patient?
So this is, unfortunately, any physician or surgeon who deals with cancer on a regular basis, this is a conversation we have to have regularly. And it's not an easy conversation ever. I think the important thing about a conversation like this is that the patient will always, once you say cancer or mass or tumor, everything that's said afterwards is almost, like you said, white noise. No one remembers most of that. So it's always important, like Deb said, to have someone in the room with you, whether it's a spouse, partner, friend, someone who can be there to kind of help interpret a lot of what's said. But it's never an easy conversation. I've had hundreds of these now, but maybe even thousands at this point of these types of conversations, and it's even though it's the same basic concept, it's always a different conversation. And part of this is as a physician, you have to read your patient. You have to both be a little bit of a psychologist or a psychiatrist, a friend, but also someone who gives informative information that then leads to the right decision making. And Deb was talking a little bit about the scary part of this, and how do you want to alleviate some of that fear. You want to sort of create an environment where, look, we're going to be working together to kind of figure this out, figure out what the next step is, and who you need to see.
Yeah. So Deb, when you were first diagnosed, tell us the next week or 2 weeks or month after that, what took place with you?
Well, initially, my sister came out the very next day to just help me, my husband, and my daughter get through this, because the conversation stops because you don't want to scare each other, and then you got to stay away from the internet. And but those first 2 weeks, you have a lot of appointments to go to, and you're just trying to keep up with all the information that's coming at you. The doctors are giving you a lot of information, and you're basically just trying to keep up.
Right. Did you find that you had a note-keeping system, or someone was keeping track of all the things that were being said to you?
Yeah, I had a notebook, and I asked questions. In fact, my doctor would say, "How many questions do we have today?" And I think the highest one I had written down was 32 questions in one visit. So, but everybody was always very helpful in answering those questions for me. So, and sometimes I repeated. I knew I asked that before. The next visit, he said, "Okay, as we went over last time," it takes a while to absorb the information.
Yeah. Sure. On that note, there's a certain stigma still around about cancer. So how did you deal with that? I know each of us deals with it a little bit differently, but did you deal with being nervous about talking about it, or afraid to talk about it, or did you just say, you know what, I've got this?
I went straight out and I just told people. And but then after a while, I had to tell people, okay, we're not talking about that anymore. Unless I want to bring it up, or and I told my friends, ask me how I'm feeling today, not in general. How am I feeling today? It helps you process it a little bit, and you don't have to talk about it every single minute and every single day. Right. And then I even actually decided in our family that we had no cancer weekends. We couldn't talk about it.
Neat. Do you have any certain tips for those folks watching today that you could help them with that initial reaction of, I've got cancer, now what do I do? Right.
It's a life-changing diagnosis or life-changing even statement, and there's a process behind that, sort of accepting what's happening and understanding what's happening. The good thing is that all cancers are not the same, obviously. There's different stages, there's different presentations. And so I think part of the first thing is, and the comfort behind this is getting the right information at hand. And like you said, the internet's a scary thing,
Yes.
because patients will show up with books and chapters, what they've gotten off the internet, and unfortunately a lot of that's misinterpreted, or they're putting themselves into a certain stage which is not their stage, or they're giving themselves diagnoses that's not part of their diagnosis. So this is where, again, we're working with your doctor and making sure that you're sort of following or trying to get the correct information makes sense, because not having the right information can also be very scary and create a lot of anxiety.
Yeah. Looks like you were going to say something.
No.
No?
Other than, sometimes that information is old.
Right. Sure.
It's outdated.
It's
Very
outdated.
much so. Yeah, I mean, Brian and I met this year at our national meeting called the American Urologic Association meeting, and even at that meeting, there's things that are coming out that just didn't exist, from a few weeks earlier, and we're constantly processing, finding new things, finding new information, new trials, new drugs, and that's the important thing with this. Kidney cancer is a very different diagnosis now in 2019 than it was even 10 years ago, and certainly 15 years ago.
Right.
We have a whole slew of drugs, new treatments that just didn't exist up until this time. Even surgically, minimally invasive techniques. I specialize in robotic and laparoscopic surgery, removing tumors, even very large ones, through small incisions. What that does is actually allows patients to recover quicker, and if they need treatments, to get those treatments quicker, get back on their feet,
Right.
get back to work. So all of these things just are a completely new world in that regard.
Yeah, when I was diagnosed in 2007, we were 1 year into the very first systemic therapy, Sutent,
Right.
and that was the one choice other than IL-2 or surgery. And now I think there are 14 or 15 systemic therapies
And
out
actually,
there.
I think there's now 16 or even 17, because there's a few more that have come down the pipeline, including really exciting immunotherapies, checkpoint inhibitors that are coming out that are really exciting stuff.
Yeah.
Combinations.
Combinations, yeah. I think one of the things that we should share with the viewers is, what were some of the support groups or resources that I know we're scared of going to the internet blindly
Yeah.
and just sort of finding things out, but are there any certain support groups or?
Yes. Well, I'm a member of smartpatients.com. It took me a while to find it. I was searching and asking questions to Google, and didn't come across real current information. And then I came across Smart Patients, and it is actually filled with patients who are going through the same thing, asking the same questions. And it's just a support group, online support group. And then from there, they started introducing other organizations that have websites with very informative information, and YouTube videos like the National Kidney Foundation is doing right now. So you start to assemble a group
Of resources.
of resources.
Yeah. Dr. Polizzi, do you have any other resources that you can share with folks?
So, I think that a lot of the national cancer organizations, American Cancer Society, they have great information there. That's always a good place to start, to get really sort of factual-based information.
Yeah.
Just so you're not getting sort of facts that are sort of old, I guess, or have been sort of misplaced. And so starting with a lot of these national organizations is always, a National Kidney Foundation, obviously, these are always great resources for finding out that initial information, and then basing your next sort of step on that information.
Okay. I'm going to make a plug too for an organization that I'm involved with called the IKCC, the International Kidney Cancer Coalition.
Yes.
They have a lot of resources
A
on their
lot.
website that you can print and download, and they even have a decision aid
Right.
that helps new patients to take into their doctors and share with them and ask questions. So that's great to know. Shifting gears a little bit, this is a little bit of a controversial question, so I'm going to delicately ask you. Historically, there are national comprehensive cancer centers in the United States that seem to be specialists, have a lot of specialists in this area. And then there's the community setting around the country where we have hundreds of doctors and institutions that are addressing kidney cancer. Can you comment on anything around telling patients that they should get second opinions? Should they go to national comprehensive cancer centers? Any thoughts on that?
So I think that's a great question. I think one of the first things that most people want to do when they get a diagnosis is get that second opinion or talk to somebody else. And I think it's a very important part of the process of kind of dealing with the information. Any physician that takes offense to someone getting a second opinion, it may not be the right physician for you. You need to have a partnership with your patient, a physician-patient relationship where you both trust each other and you're both comfortable with each other. And if one of those two parties is not comfortable, then clearly you're not going to get the best care possible. And so getting a second opinion, I think, is absolutely an important part of any sort of decision-making process. Here in New York City, we have many great centers and great physicians, and so having patients come in, having second, third, fourth opinions is very normal for me. I'm used to that. I don't take offense to that. I don't think most of the physicians here do. It might be a little bit different in other places in the country where you may have to drive 100, 200 miles to get another opinion. But here we have that luxury that there's really so many good physicians in the same area. That being said, community medicine is still great medicine. We don't want to sort of say that necessarily that you have to go to one of the largest centers in the world or a center that specializes in one thing, but you want to go to a center that has experience. You want to go to physicians that have experience. So what are called high-volume centers, places that are used to doing these kind of surgeries, places that are used to taking care of patients with these types of problems. Study after study have shown that the outcomes are really improved by going to high-volume centers, high-expertise centers, and you can get that in community medicine, no question, absolutely.
Got it. Do you want to comment, Deb, at all?
Well, I know a number of folks that I've met through this journey. They've actually gone to a high-volume comprehensive center to get an opinion, and that doctor is communicating to their local physician, who may not have seen very many kidney cancer patients, one or two a year, but the other doctor in the comprehensive center actually emails back and forth. They chat on the phone and keep everybody moving forward.
Yeah.
No, I think that's a great point, actually. And I work with a lot of physicians around the country who send their patients to New York, and we send them back regular emails and obviously notes, and we work with a plan with them, working with their local oncologists, even if we need to get someone involved. So this is great.
Yeah, and actually my second opinion doctor told me to go with my first doctor because he knew that he had more to offer me as far as clinical trial options and everything. So my second opinion doctor told me to stick with the first.
Right. Well, I was diagnosed in Washington, D.C., and I was told unequivocally to get some second opinions in some of these other institutions. And so I did that in Philadelphia as well as in New York. I was fortunate. And then it was also picked up by the NIH. And so I was very fortunate to have them take a look at me. And it helped a lot with having these experts in the field weigh in on your situation, and it helped validate what you were going through. Anyway, so I think at this time, why don't we take a few minutes to answer some of the questions from the folks tuning in. If you have any questions on this subject, go ahead and post them in the comments section, and we'll do our best to answer as many as we can. If we run out of time, all your questions will be answered and addressed on the National Kidney Foundation and kidneycan.org's Facebook pages after the program. Well, so it looks like we've got our first question, and this one's for our patients. For our patient, Deb, so how do I assemble and work with my healthcare team? Who should it include, and how do I maintain communication with everyone? We've touched on this a little bit, but please.
We touched on it a little bit, yeah. But, and everybody is going to be different. It all depends on what you had going into this diagnosis and what kind of medicine you're going to be taking. Because some of the medicines that you have different reactions to the body. And so as you go through your journey, as you get a symptom or a pain, you keep that communication open with your doctor. And I'm fortunate, they have a portal. I can send information through the portal, and the nurse practitioner calls me all the time. So you just have to ask for it and keep it moving forward.
Well, one of the topics that's related to this in assembling a healthcare team is this new concept, or relatively new concept, of shared decision making that's been out in the in our community these days. Do you want to just tell us a little bit and define shared decision making?
Sure. So it's become a buzzword, like you said. It's something that is defining the relationship between the doctor and the patient. We use it a lot in prostate cancer in my world, in urology. Clearly, we use it also in kidney cancer and bladder cancer, things like that. But it's basically a word that's there to help identify or put a label to a doctor-patient relationship. Okay, and where you're making decisions together, as opposed to the doctor saying, "Listen, we're going to send you for chemotherapy and radiation and this and that, and I'll see you next week." That was sort of the old model. I think that was very evident when our grandparents were alive, and that's changed a lot in the last 20, 25 years. And so, like you said, you want to have a rapport with your patient, and also with your doctor, and also the cancer team, the team that's taking care of you. The day and age now of having these electronic medical records makes that so much easier. The ability to have a portal to sort of send in a question or an email. Those days of kind of having to pick up the phone and having a long conversation, you don't really need that anymore, because most of the information you can do through just sort of a social media kind of platform, and obviously a closed one. You don't want to make it so that everyone can get access to it.
Obviously.
But you want to have a private portal that allows you access to your doctor and your team.
Got it. So on the shared decision-making theme, I grew up with sort of a paternalistic understanding of the doctor-patient relationship. It was sort of hierarchical. And now it seems to be shifting to more of a horizontal, where the patient is at the center of the sort of concentric circle of all the different caregivers and all the providers. Do you see this? Do you have any way to make sure that this is happening with all of your patients across the hospital?
So that's a great question too. So if every one of my patients, and I see literally hundreds a week, were to send questions in and phone calls, it would be almost impossible to do that. And that's why it's actually good to have a good team yourself. So I have an excellent team that I work with, from my physician assistant, my nurses, my assistants. I couldn't do my job without them, and they really are the backbone of everything that I do. And so they're the ones that help me really deliver good care and deliver sort of information back to our patients. And so that's an important part of having finding a doctor or finding a place is that person has a good support network as well.
So I'm going to shift a little bit of gear here. Back to our issue of getting second opinions, which you do regularly. Do you ever encounter situations where you get conflicting opinions and then the patient comes back to you? Sorry to put you on the spot there.
No, sure. That happens quite often as well. Sometimes those conflicting decisions are a little bit based on, lack of a better word, is just some, I wouldn't say necessarily jealousy, but there's definitely some interactions that go on with physicians where there's a competition that occurs, and so sometimes you'll read your patient and may tell the patient something that they may want to hear, but may not necessarily always be the correct decision, or there may be two decisions that could be correct, and so one may be more preferential than the other based on the information at hand.
Yeah.
So it's not black and white by any definition of the word, and so there's definitely a gray zone with all this, and so I think you have to take that's why you have to be comfortable with your physician or who your care partners are, and making sure that you trust them.
Did you ever have any situations where you got two conflicting opinions or divergent opinions?
No, but when it was my time to make a decision on what steps I was going to take moving forward, my doctor gave me 3 or 4 options, and I had to choose. So I had to start reaching out and asking other people, asking nurses that I came across with, asking other patients, and then making my decision and going from there.
Right. No, I nothing derogatory in this statement, but I was told point blank by one of my physicians early on, Brian, we're still in the practice of medicine, emphasis on the word practice. Mm-hmm. And so you do have to do your homework. Yes. You have to go to resources and go to third parties and validate some of these issues. And
sure.
So
you have to be your own patient advocate.
Yeah.
You are.
Take ownership.
Yes.
Exactly. So here's another question. How do I address, we touched on this one a little bit, how do I address the emotional, psychological, and social impact of my diagnosis? And so I'm going to point to you.
That's a hard one, and again, everybody is different. Some people need more conversation around it to feel better. In my case, I just stopped talking about it a lot, and I started painting all the walls in my house and just keeping myself busy.
Yeah.
If I don't keep myself busy and I allow myself to sit down, I can get in a funk, and it could last a couple of days. And then you feel bad because you're just not doing anything. So it snowballs.
Yeah.
So you have to find what you like and what keeps you from dwelling on it.
Right. I think reflecting personally, and for those listening out there, everybody's case is unique, so I don't want to tell you that my advice is the right advice here. It's just my perspective. I found that there were periods like you where I did not want to talk about cancer. I had gotten through it, and I was moving on with my life, and I'm going back to living normally.
Yeah.
Even though you don't fully return to normal,
No.
I'm just going to move on and have those blackout periods. And then there's this issue of coming up against scans and the time for scans, and that can be an emotional roller coaster.
Scan anxiety.
Scanxiety, yeah.
Scanxiety.
That's another issue. So I'm going to get a little technical here, Dr. Polizzi. So how is it staged? How do you stage kidney cancer? Because there's a lot of new words that people that are diagnosed have to understand. And talk to us a little bit about staging.
So kidney cancer is unique, or not so unique in the sense that we use a staging system that most other cancers have. There's a stage 1 through 4 with a TNM staging, and TNM stands for tumor, node, and metastases. So whenever you're diagnosed with a kidney cancer, we first look at the size of the tumor, then we look to see whether or not there are any lymph nodes involved, and then we look to see if there's any tumor or any metastatic lesions, so if the cancer looks like it's grown out of the kidney itself. And then we assign it into one of those stages. Stage 1 is obviously the preferable stage, localized cancer, stage 1 and 2. Stage 3 and 4, more a regional cancer or a metastatic cancer, and each of these carries different prognoses and sort of long-term survival. So the typical sort of cutoff for stage 1 to stage 2 in terms of sheer size is 7 centimeters. So if you're above 7 centimeters, you're really a stage 2 or higher. Below 7 centimeters, you're a stage 1. So actually a decent size in terms of how much a kidney can grow.
How big, for us non-metric folks, how big is 7 centimeters?
Yeah, it's a little over 2 inches, basically.
Okay,
Yeah,
about the size of a golf ball?
A little bit bigger than the golf ball, yeah, a little bit bigger than the golf ball, exactly. And I think that's one of the first things we always want to find out when someone's been diagnosed is try and figure out their clinical stage. So that's different than the pathologic stage, which is once you've actually removed the tumor and you actually have then a diagnosis, you can then you can restage it to determine if it's, for instance, the tumor is bigger than you thought, or for instance, the lymph nodes, there are lymph nodes that are involved. So quite often during the surgery, we'll remove a packet of lymph nodes in the area that will help with staging.
Got it. Quick question. Do you remember what stage you were when you were diagnosed?
4.
Okay, and I remember as well, but the TNM I forgot to write down, and I had to go back and get later. So again, to those folks watching, make sure to take notes. It's extremely important if you go for a second opinion that you have all of these details. Right. And that's sort of a segue to this other comment I want to make, which is during that white noise period of after diagnosis, you are just inundated with all kinds of new language. RCC, the word oncology, staging, tumor, nodes, metastasis, all these new words, new vocabulary you have to learn. Are there any resources or other things that you could recommend, or what do you tell the folks out there that when you're thrown into this deep end of new lingo?
So again, that's going onto websites or to sites that have a national chapter, like the American Cancer Society is a wonderful place to start. They have a lot of definitions on there that will help to wade through this sort of information that's there. Let you then kind of make that decision if the scary word is not quite as scary as you think. It's just sort of a descriptive word, a descriptive term. And cancer, like I said before, not all cancers are the same, and that's what's important here.
Yeah.
There's a lot of acronyms too.
Yeah, and I think we're going to be posting a lot of these resources on the websites of both of our organizations after this. So for folks out there, you'll have access to some of these websites later on. So, well, it looks like we've reached the end of our time here. A quick reminder, this is the first of a 3-part series on this subject, and I encourage you to join us 2 weeks from today on Monday, June 24th, where we'll be discussing kidney cancer treatment options. And in case we didn't get around to answering your question today, please check back on the National Kidney Foundation and Kidney Can's Facebook pages, where we'll be posting the answers throughout the coming days. And I'd like to thank our sponsors for their generous support in making this program possible. And I'd especially like to thank Dr. Polizzi and Deb for joining us here today and helping us to make sense of what I know can be a life-changing, psychologically and emotionally challenging subject for so many people. Thank you very much for coming.
Thank you so much.
Thank you for the
Appreciate it.
invitation.
On behalf of the National Kidney Foundation and Kidney Can, I'd like to wish you all good health. Thank you.